Greetings, participants. Happy New Year and welcome back to the AfricaCalls Cytopathology series. It's my great privilege to introduce today's speaker, Dr. Peter Ile. I'm Dr. Leslie Lomo here again from the University of Utah in Salt Lake City to moderate this session with my co-coordinator from Stanford University Pathology Department, Dr. Ali Lowe. Dr. Ile obtained his medical degree at the University Medical School of Pécs in Hungary, completed his combined anatomic and clinical pathology residency training at New York University Medical Center, followed by cytopathology fellowship at the Memorial Sloan Kettering Cancer Center in New York. Dr. Ile is an associate professor of pathology and oncology at Johns Hopkins University School of Medicine in Baltimore, Maryland, where he is an attending pathologist in the divisions of cytopathology and surgical pathology, and is the director of the Thoracic Pathology Consult Service. His main clinical interests span thoracic surgical pathology and cytopathology with a focus on neoplastic diseases and lung transplant pathology. His research interests include the development and application of biomarker testing in thoracic malignancies, novel and diagnostic and therapeutic markers in malignant mesothelioma, and the surgical pathology and cytopathology of thoracic neoplasms. He is nationally and internationally renowned for his expertise in these areas, having published extensively, been involved in the generation of consensus evidence-based guidelines for collection and handling of thoracic specimens for laboratory testing, and served as faculty in numerous educational courses and workshops in national and international meetings. And so we are so very thrilled to have him present today on his presentation entitled Challenging Cases in Thoracic Cytopathology. So with that, I'll turn it over to Dr. Ile.
Thank you very much for the kind introduction, and hello everyone. Let's go and share my screen. I'm going to turn my camera off while I'm talking, so there should be no distraction. Oops. Okay, so the title of my topic today is Challenging Cases in Thoracic Cytopathology. We will look at a couple of cases, and during those examples, we will discuss the findings and the background information in order to render the correct diagnosis for those cases. So these are my disclosures. And so the objectives of this presentation is to recognize cytologic, histologic features and immunophenotype of rare thoracic tumors, including thoracic SMARCA4 deficient undifferentiated tumor and not carcinoma. Recognize cytologic features of pulmonary hamartomas in fine needle aspirates and corresponding histologic findings, and provide clues to differential diagnosis of pulmonary neuroendocrine neoplasms, including tumor grading and distinguishing between primary and metastatic processes. And look at cytology clues and practical ancillary studies in the differential diagnosis of malignant pleural effusion, mesothelioma versus benign mesothelial proliferations, and versus metastatic processes. So this is what we try to achieve today. So let's just very briefly look at the 2021 WHO classification of thoracic tumors. That's the cover page right there, and shows on purpose, it shows a CT scan, some cytology, and some histology. And the previous edition also showed some, molecular graphs. This is to emphasize that lung cancer or thoracic tumor diagnosis is a multidisciplinary effort where clinical features, imaging studies, and cytology pathology are essential to make the diagnosis, and then this has to be subjected to molecular studies to provide biomarker information. The middle panel here shows the current groupings of tumors, and I'm focusing on sort of rare tumors, including under the category of other epithelial tumors is not carcinoma, and thoracic SMARCA4 deficient undifferentiated tumors. This is what we're going to discuss today. The adenoma group includes sclerosing pneumocytoma, formerly sclerosing hemangioma, alveolar adenoma, papillary adenoma, and a new entity that was not included in prior editions called bronchial adenoma, which is a broader category that previously included ciliated muconodular papillary tumor. Those are really not subject to diagnosis on cytology, and therefore we're not going to discuss them. So case one, the patient has a history of laryngosquamous cell carcinoma. He had definitive surgery and chemoradiation. And now, a few years later, there's a newly detected mediastinal lymphadenopathy on CT scan. A station 7 lymph node was biopsied using endobronchial ultrasound FNA. So these are the Diff-Quik stain smeared. In our laboratory for air-dried smears, we use the Diff-Quik stain. And on the left panel is an intermediate to low power, showing you the general cellularity of the smears, which is pretty good. And there is some dirty background, so there is some cell debris in the background indicative of necrosis. On higher power, in the middle, we can see that these are, somewhat branching clusters of cells that have some cytoplasm, dense bluish cytoplasm, and large nuclei with rather prominent nucleoli. And on high power, on the right side, which was under oil, so it's 100x magnification. I mean, it's 1000x magnification. And here we can see the nuclear features even better. The nuclei have relatively irregular nuclear membrane and somewhat irregular chromatin with prominent nucleoli. And some of the cells, where there's intact cytoplasm, the nuclei are pushed to one side. Here's the Papa-Nicolau stain of the same case. Again, intermediate low power shows similar cellularity. And again, you can see that the cytoplasm has somewhat basophilic appearance, denser qualities, and the nuclei are mostly centered in the cell, in the center of the cells, but in some cells it's eccentric. The prominent nucleoli are even better appreciated on this stain, and there you can see some irregularity of the nuclear membrane. The cytoplasm is not quite dense enough to what we typically see in squamous cell, and no orangeophilia here either. So this is a cell block. Actually, what we do is the clot method, when the contents of the needle are placed on a lens paper and together with blood, and these clots and additional passes are added to this preparation, and finally we get a nice blood clot on the filter paper, somewhat similar to a bone marrow clot, and then this is put in formalin and processed like a biopsy. So the material from this method is very good. It's formalin fixed, and which is advantageous in our laboratory since all our ancillary studies are standardized for formalin fixed tissue. So here we can see on low power an area of necrosis, and then densely packed tumor cells, which on higher power have a centrally placed nuclei with prominent nucleoli and somewhat lacy cytoplasm, and maybe some intercellular junction. And again, under oil, we can see mitotic figures, apoptotic bodies, and the prominent nucleoli with some irregular nuclear membrane. So these are big cells, big nuclei, and very prominent nucleoli. And necrosis is a poorly differentiated neoplasm. So then we subjected to immunostains, and we found that the tumor cells were CK7 positive, not surprisingly since we are in the chest. It was also CDX2 positive and TTF1 negative. I show a summary of all the stains. And because of the prominent nucleoli, the somewhat eccentrically placed nuclei, and the large size of the cells, we did the BRG1 immunostain, which it detects the protein for SMARCA4, and when it's lost, it is indicative of SMARCA4 deficiency. And as we can see here, the loss is in some areas complete, in other areas it's partial, but markedly reduced staining pattern compared to the internal control non-neoplastic cells. So this is an attenuated expression. Here is the summary of the additional stains. So cytokeratin, pankeratin was positive, CK7 was patchy. Some areas were very strong, others were less staining, and CDX2 was also positive. Negative were TTF1, CD68, P40, P63. So which are P40 is our favorite squamous marker, and indeed this thing, and as well as GADAS3 and CD34. The negative P40 staining is strongly against the metastatic squamous cell carcinoma. We also performed the SMARCA2 immunostain, however, that should retain expression. So, in the final conclusion, this is a tumor with epithelial differentiation and loss of SMARCA4 as evidenced by attenuated expression of BRG1. So we made a diagnosis of a SMARCA4 deficient undifferentiated tumor. Let me show you some other examples of this entity. Here's a pleural effusion in a patient with a large lung mass. And in the pleural effusion, it's highly cellular. Basically, most of the cells are malignant cells. And you can see this eccentrically placed nucleus with the cytoplasmic inclusion or density, some sort of indenting the nuclei, sort of a rhabdoid look to these cells. And you can look at there are no fuzzy borders at the periphery, no skirting, like the features that would be associated with the mesothelial proliferation. Here's the cell block, where you can see in some cells that they are markedly enlarged nuclei and a prominent nucleoli, although the most cells have smaller nuclei with this vesicular lobulated chromatin pattern and irregular nuclear membrane. In this case, the BRG1 stain shows complete loss of expression. This is another case from a 66-year-old female patient. This is a right upper lobe mass, finely aspirate. Again, here on the left side, we see a cellular smear at the intermediate power with some, naked nuclei where the cells lost their cytoplasm, very fragile cells. And then when we focus in on higher power, we can see that the nuclei, again, are round, oval, somewhat irregularly shaped. They have relatively evenly distributed chromatin and prominent large nucleoli, as shown here on the oil. And this is a core biopsy of the same process, and it shows that the tumor forms sheets and has variable amount of cytoplasm. In some areas, it's more denser appearing eosinophilic cytoplasm. However, the nuclei are markedly enlarged, irregular, and then they have these little bubbles in the chromatin. And here's a BRG1 stain from two different areas, and showing complete loss or attenuated expression. If we see complete loss or attenuated expression in over 50% of the tumor, that is considered significant and is sufficient to render this diagnosis. And here are other stains from the same patient. We can see that in this case, the tumor cells show some staining for TTF1. These stronger staining cells are likely residual pneumocytes in the background lung, that this alveolar space was colonized by this tumor. And interestingly, synaptophysin is also positive. This can be seen in these tumors, not infrequently, at least in part of the tumor. A SMARCA2 stain in this case showed complete or near complete loss of expression. So this case had both SMARCA4 and SMARCA2 deficiency, which is seen in about a little less than half the cases. This is a transbronchial biopsy, no cytology available for this case. As you can see, it's a sort of an endobronchial biopsy, the piece of the bronchial mucosa. Here's a normal ciliated epithelium right here. And undermining this is a solid nest of tumor, where we can see that these tumors have prominent, large, round, irregular nuclei, prominent nucleoli, and this eosinophilic cytoplasm. In some cases, in this tumor type can have a haploid pattern. So we performed a HEPR1 stain, and this is what we saw. This, in our interpretation, is non-specific, as this staining is not granular. And then I caution people when they use HEPR1 to only accept granular staining, and I'll show you an example soon. So carotene was negative in the tumor cells, and BRG1 showed complete loss. So this was another case from a 62-year-old female patient, and this patient presented with a lung mass and a liver nodule. So the liver was biopsied, as you can see here. There's some lymphoid follicles, and then there's lymphoid infiltrate. There's this hepatic tissue, and in between the hepatocytes are these tumor cells, which have somewhat similar cytoplasm, and again, enlarged nuclei, bigger than the residual background hepatocytes, and prominent nucleoli, and somewhat similar cytoplasmic qualities with some evacuation of the cytoplasm. So here's the immunostains. HEPR1 stain in the middle. You can see the background liver shows nice, strong, granular cytoplasmic staining, and then the tumor cells show complete lack of staining. And similarly, the BRG1 stain is positive in background liver cells and the lymphocytes. We also did an INI1 stain, which is SMARCB1, recognizes SMARCB1, and there's no loss, there's retained expression, both in the tumor and in the background benign tissue. Overall, the immunohistochemistry showed that the tumor cells were cytokeratin positive and CK7 positive, and focally positive for CDX2 and PLAP, and negative for CK20, PAX, ATTF, OX34, CD30, P16, P40. This is the final example of this tumor. This was a mediastinal mass, again, and a 76-year-old male, and no cytology available. Had the large cystic area that was lined by neoplastic mucinous epithelium, and also some acinar structure were seen in between. And the majority of the tumor showed these nest sheets of pleomorphic cells that had dense cytoplasm pushing the nucleus to one side. It's a very rhabdoid appearance, again, prominent nucleoli and irregular nuclear membrane and somewhat coarse chromatin or open chromatin. The CAM 5.2 stain showed strong staining of the glandular mucinous component and focal staining, patchy staining of the rhabdoid component. And BRG1 was lost in the fully differentiated component. So this entity of SMARCA4 deficient undifferentiated tumor evolved in about the last 10 years. Initially, some of the tumors can be keratin positive, others are negative. It was found that the keratin positives were carcinomas, versus the keratin negative were considered sarcomas. With more examples and more data available, we now feel that the WHO classification suggests that it's still unclear where exactly put these tumors, but the SMARCA4 deficient tumors can exhibit both keratin positivity and negativity, and so right now they lump together. They can also have a component that shows clear glandular adenocarcinoma differentiation and less commonly squamous cell differentiation. These are aggressive tumors. TTF1 is typically negative or only focally positive, even less commonly focally P40 positive. As shown here, the typical features are rhabdoid pleomorphic features with prominent nucleoli and sometimes hepatoid pattern. The loss or attenuated expression of SMARCA4 with or without SMARCA2 loss. The majority, about 80% or so, maybe a little more, of these tumors have an inactivating mutation in the SMARCA4 gene, but that being said, about 20% do not have that, and inactivation is by other means. Other driver mutations like KRAS mutation can also be detected in a subset of cases. Interestingly, these tumors can have, and this is where on small biopsies, the diagnosis can be difficult because they can show aberrant expression of synaptophysin, CD56, CDX2, HEPR1, glypican-3, for instance. So they can express other markers in a non-specific way. They represent an emerging category of high-grade thoracic malignancy that are thought to be genetically related to non-small cell carcinoma and likely represents an undifferentiated sarcomatous carcinoma rather than a true primary sarcoma. They're more aggressive than stage for stage non-small cell lung carcinomas and have a poor prognosis with the majority of the patient dying within a year of diagnosis. So case number 2. This one is a 26-year-old male patient with right mediastinal mass and an EBUS station 7 lymph node was performed. Here we can see dispersed tumor cells with scanned cytoplasm, very basaloid appearance. Here they form some of the like a trabecular structure. Here it's more like a wider cluster. As we can see that the scanned cytoplasm, nuclear crowding, but there's no molding appreciated on this image. On Pap stain, we can see that in some areas there are dispersed cells mixed in with lymphocytes, and then we have these other clusters with some whirling areas in the center and better appreciated on this feature, like appearing almost like a squamous eddy. This is the cell block. Again, it shows a very basaloid, poorly differentiated neoplasm. With scanned cytoplasm, dense, evenly distributed chromatin, numerous apoptotic cells, and occasional mitosis. And the numerous stains were performed, and one that was positive was glypican-3. And here's the higher power of those two clusters of cells. And here we can see that there is a somewhat squamoid appearance in this area with some whorls as well as here. Nevertheless, this was the staining pattern at the end of the workup, and the CD45 was equivocal. I think they stained the background lymphocytes. The CAM 5.2 was negative, as were CD30, OX34, PLAP, CEL4. So those are germ cell markers, all negative, as were CK7, TTF, CK20, and NFCNA. Unfortunately, these stains were non-contributory, and flow cytometry on the separate part of the aspirate was negative for lymphoma. So because of the patient's age and the glypican staining, initially that case was diagnosed as a fully differentiated epithelioid neoplasm, suspicious for a germ cell tumor. A few months following that biopsy, a bone metastasis was discovered and a core biopsy was performed, where you can see the same nested cells infiltrating the bone with some destruction of the bone. And in this case, a P40 stain was performed, which showed diffuse staining. And following that, a NOT1 stain was also performed that showed diffuse nuclear labeling. So the diagnosis was changed to NOT carcinoma. Again, subsequently, within a short period of time, the patient developed pericardial effusions, and here are the intermediate power and high power view of that infusion, where we can see these basaloid cells singly and in small clusters, and lining up in a single line, and they have relatively scant cytoplasm. Some have nucleoli and somewhat coarse chromatin. Here's the cell block, the same cells, and the NOT1 stain on the right. So this is a positive pericardial fluid. This is another patient, a 34-year-old man with a skull-based tumor, where the diffuse stain showed this very basaloid neoplasm with nuclear crowding and molding, and some streaming of the chromatin. And on another area, we can see that the somewhat coarse chromatin, maybe occasional nucleoli. Here the cells are a little more separated. And this is the corresponding agent section from the cell block. And we can see here that the cells have a more open chromatin, small nucleoli, mitotic figures are abundant. And in other areas, a little better preserved cells have more squamoid appearance with abrupt keratinization. And this is a key feature of this tumor. When present, it's really makes the diagnosis so much easier. When you can see this mostly basaloid squamoid pattern, and then a focus of the small abrupt keratinization, or as in the spirit of the first example, you saw the squamous eddies. Here's another case from a 4R lymph node, and on the smear, there were background lymphocytes and the smaller clusters of basaloid cells. And in the cell block, we got lucky. We got this large sheet of basaloid cells with little cytoplasm, but the nuclei have open chromatin and small nucleoli. And again, the small abrupt keratinization, like this squamous marule almost, and somewhat more cytoplasm in this area. And the NOT1 stain was diffusely positive, including this area here, which is as over here. So for NOT carcinoma, as was introduced in the WHO at 2015, formerly was known as midline carcinoma or midline carcinoma of the young. It's typically in younger patients, but it can occur in any age, even elderly. They can occur most commonly in the thoracic cavity and in the head and neck region. They can show neuroendocrine differentiation. They can have even small cell carcinoma areas. Can have inside the squamous component, especially in the head and neck. The majority of tumors are P63, P40 positive, but they can be negative and they can be keratin negative. And the FACE or IHC showing the NOT translocation or NOT protein expression is diagnostic. NOT protein is only expressed in sperms, so in any other normal tissue, there's no NOT staining. So you can use test this for a control if that's what you're looking for. The immunostaining is quite simple to perform. There's a NOT carcinoma registry at Harvard University, and there is a clinical trial with a targeted therapy available for these patients. However, most patients, due to the very aggressiveness of this tumor, die within a year. So case 3, so I'll be moving to another topic, is a 73-year-old male with a 5-centimeter left upper lobe lung mass and central calcification. Here's a CT scan where you can see that on the well, sorry, this is the left upper lobe. No, this is right upper lobe, that's correct. This is anterior posterior is a CT scan is flipped. So this is right upper lobe here, right from the main bronchus, is a round, very relatively well circumscribed nodule with some central calcifications. This is the gross specimen before it was cut. Unfortunately, the resident did not take a photo after the sectioning of the tumor of this lesion, and so we don't have that. So here's an FNA. The FNA was performed prior to the resection, and showed a few of these clusters of mesenchymal fragments with a lot of vessels, as you can see here, very bland cells, some spindle cells, some myxoid stroma. And in other areas, again, was more like the myxoid, chondromyxoid matrix was a little more prominent. Again, another stromal fragment. And then you can see scattered atypical epithelial cells with relatively normal answer ratio, but enlarged nuclei, somewhat irregularly shaped, pushed to one side, sort of plasmacytoid, maybe a binucleated form. Here is the higher power of this area, the fibromyxoid stroma, the cluster of atypical cells. Here's the binucleated cell. And this one is that larger clusters of epithelial cells that look like pneumocytes with atypia, like a well-differentiated adenocarcinoma or formerly known as BAC, or now AIS or lipidic tumors, often have this appearance on FNA smears when aspirated. So here we can see some plasmacytoid cells with markedly enlarged nuclei, some markedly enlarged nuclei without cytoplasm. So there's a fair amount of cytologic atypia in the epithelial cells. Here's under oil. We can see the chromatin is evenly distributed, and there is some space between the cells. So this is highly suggestive of pneumocytes. The cell block had a few scattered atypical cells in the blood, and that were really highlighted by immunostain for TTF, 1 NAFCIN and P40. This is a triple stain that we use. So it's a multiplex stain. So TTF and NAFCIN is brown, and P40 is red. So if it's brown, it's glandular. If it's red, it's squamous, and it is a really good stain. And it only requires 1 slide. You could also do this on a smear. There was some fragments, and in the fragments there was some stroma and lined by ciliated and non-ciliated epithelium. And here we can see some red cells. So suggests, demonstrating that indeed these are respiratory epithelium with some flattening of the cells. And in the background, again, we see these TTF positive scattered cells. So a diagnosis on the FNA was atypical pneumocyte proliferation. Keep in mind that the cytologist who read this case did not see the CT scan, did not see the gross specimen. Upon resection, a large wedge resection or segmental resection was performed, and this is what we got. Here's an airway, and next to the airway was this cartilaginous tumor with intermixed adipose tissue, and some on higher power you can see myxoid stroma and some epithelial cells, atypical epithelial cells that I will show you more examples here. These are epithelial cells with atypia, some degeneration, and highlighted on TTF stain. And in other areas, there were crevices, cracks, and these trabecular structures lined by these atypical epithelial cells. Some had inclusions, like here, grooves, some overlapping, so like a papillary type nuclear changes. So there is a pneumocyte atypia, sometimes, maybe even nesting a little bit. And so the diagnosis was made on the resection to cartilaginous pulmonary hamartoma with marked pneumocyte atypia. So pulmonary hamartomas are considered now benign mesenchymal neoplasms, and by definition, they have to have at least 2 mesenchymal elements and then trapped respiratory epithelium. So here we have cartilage, fat, fibromyxoid stroma, and the epithelium. The majority, 90%, are peripheral, but 10% can be centrally located centered in a bronchus, like in this case. Peripheral hamartomas are typically well circumscribed, they're asymptomatic, and usually discovered incidentally as a coin lesion on CT scan or X-rays. They often calcified, and then they have this special popcorn pattern is present that can be diagnostic together if fat is appreciated on CT scan. They are FDG low avid, so the PET scan is negative or just very light labeling. Molecular studies have shown that there's the leading fusion, the translocation leading to a gene fusion of the chromosomes 3 and 12, involving these arms and regions, and resulting in HMGA2 LPP fusions. It's usually between exon 1-3 of HMGA2 and exon 9-11 of LPP. This fusion is also seen in lipoma, so not quite surprisingly. These are slowly growing tumors. If entirely removed, recurrences and malignant transformations are extremely rare. Histologically, we see most hamartomas contain variable amount of hyaline cartilage and fat, but we don't interrupt lung epithelial cells that sometimes are difficult to spot. In other cases, they can be abundant. Other stromal elements, usually smooth muscles or myxoid change, can also be present. Endobronchial hamartomas may contain a large amount of adipose tissue, and then these are also known as lipomatous hamartoma. In any hamartoma, stromal overgrowth can occur, for instance, by smooth muscle or myxoid matrix or mixed fibromyxoid cells. And if it's smooth muscle, the term adenolyomatous hamartoma is used. And this can pose a difficulty for separating from benign or low-grade mesenchymal tumors, or in females from metastatic smooth muscle tumor, like benign metastatic leiomyoma. Cytologic findings. On cytology smears, you may see hyaline cartilage, but that since these are typically FNAs, if they are small, they are difficult to distinguish from bronchial cartilage. Fibrous or fibromyxoid stroma, scattered epithelial cells that can be atypical, and the atypia can be marked, and the number of cells can be numerous and can mimic carcinoma. So this is a trap, well known, and some of that has to be looked out for. And the trick to not to do the wrong diagnosis is to know the findings on imaging and the clinical presentation. The FNAs can also have very scant cellularity, and there might be extensive calcification and some bone fragments. Differential diagnosis. As alluded before, monomorphic soft tissue tumors, benign or low grade, and pulmonary chondroma. Now, pulmonary chondroma has no fat and no entrapped epithelium. It can be, however, calcified or heavily ossified. And they also have a fibrous pseudocapsule. The pulmonary chondromas are most common in patients with carni triad, which is gastrointestinal stromal tumor, pulmonary chondroma, and paraganglioma. So these are typical FNA findings from a peripheral pulmonary hamartoma. It is this myxoid stroma with scattered spindle cells, relatively bland epithelial cells in some areas with atypia, suggesting of an epithelial neoplasm. And here's a piece of hyaline cartilage. So this is, typically what we see in an aspirate of a pulmonary hamartoma. So let's look at another example. This is from also from a right upper lobe lung mass. Here it's very ossified, radiodense area, sort of a nice surrounding, and then there is more dense collapsed lung around it. And here's the lobectomy that was performed, or a large segmentectomy that was performed, and here's an airway, and there is this cartilaginous appearing product in the lumen. The cross section after fixation shows bone, an ossified area at the periphery, and yellow fatty areas in the center. Aspirates that were performed before the resections are shown here. A lot of the material was just benign respiratory epithelial cells, where you can see the terminal bar and the cilia at the end. And however, there were a few stromal fragments, as shown here, and with small spindle and round cells. It's hard to distinguish them on this district stained smear. Here is the PAP stained smear, the large fragments of stromal spindle cell stroma, and here there's cartilage with some ossification. And in higher power, we can appreciate the cartilage here. These dense sustaining areas are more calcified, and then there is the spindle cell in this dense matrix. And when you focus up and down, there's some chondroid cells can be appreciated in this area as well. Another fragment, more cellular, the spindle cells are more packed together. Again, the nature of these cells is somewhat unclear on these smears. And here is a fibrovascular stroma with some myxoid matrix. This was the resection. This is a 5 centimeter section. It's a large block that we could put in here, and it's really useful to evaluate the location of this tumor. This is the surrounding collapsed lung, and there was more of that. There was a post-obstructive pneumonia present. So here is a relatively well circumscribed, but there's no fibrous pseudocapsule. This is the glands of the submucosal glands of the bronchial epithelium, the original bronchial lumen. And there's some ciliated epithelial cells here. So this might be still part of the same lumen. And here is the lesion itself with a lot of cartilage and ossification. So when we go on higher power, we can appreciate the hyaline cartilage. It's somewhat irregular, very cellular, mixed with fat, and in other areas, some myxoid, fibromyxoid cells, as shown here, and then there was a few entrapped epithelial cells that I'm not showing here. So this was diagnosed as a pulmonary hamartoma in a bronchus, removing the bronchus with extensive ossification. The specimen actually was difficult to cut and had to be decalcified before further processing. So moving on, the next case is a 58-year-old woman with a mediastinal lymphadenopathy and of a station 7 lymph node. EBUS of a station 7 lymph node. So some of the smears showed abundant bronchial cells that in clusters, and then in other areas there were atypical cells that had very similar cytologic nuclear features, but no cilia or terminal bar. And this is always a problem in endobronchial aspirates to know whether these are bronchial cells or some other epithelial cells. And in other areas, it was easier to distinguish the bronchial cells from these clusters of atypical cells. They're more densely packed here. Here we can see some bridges or junctions between the cells, some small nucleoli, but no terminal bar. And compare this to the bronchial cells in the background. Here's another cluster of atypical cells. Very evenly distributed chromatin in most of the cells and regular nuclear membrane. Here's a Pap smear, Pap stain. Here we can see the mucinous cells of the bronchial epithelial cells, and then still here these are cells that we do not appreciate the cilia or the terminal bar, and then they have a higher NC ratio than the background bronchial cells. Same here. Here there's some myxoid material in the background. This is the cell block clot preparation, where we can see these large sheets of cells. There's some necrosis, cellular necrosis over here. And on in intermediate and high power, we can appreciate that the cells have eosinophilic sort of scant or moderate, medium amount of cytoplasm, and the nuclei are enlarged. Most of them are round or oval and have evenly distributed chromatin. Some have small or inconspicuous nuclei, and they form this large sheet no molding, no nuclear overlapping was seen. Somewhat like atypical carcinoid tumor would look like. So the cells were CK7 positive, synapto and chromogranin positive, with a very high Ki, even though mitotic figures were not easily appreciated on the cell block. So the positive stain included pankeratin, A1, A3, CAM 5.2, CK7, CK56, synaptophysin chromogranin CD56, which was focal, and the Ki was 80-90%. Negative stain, CK20, P63, TTF1, GETA3, PAX8. So how do we classify this tumor? So we felt that on cytology and morphology, he had somewhat a carcinoid-like morphology, but it was much higher grade, as evidenced by the proliferative index, and there were also mitotic figures, but they were not more than 10 per 2 square millimeter. So we called it a metastatic neuroendocrine carcinoma with carcinoid-like morphology, best classified as large cell neuroendocrine carcinoma. And this is what currently the WHO recommends for this kind of tumors. However, we got a call from the clinician who said the patient has a large inguinal mass, and clinically they're really suspicious for Merkel cell carcinoma. Could this be a metastatic Merkel cell carcinoma? So we did additional immunostains, one for the Merkel cell polyomavirus and one for neurofilament. And the polyomavirus was negative, but the neurofilament was diffusely positive. And we also did a PD-L1 stain that showed almost every tumor cells positive. So this, in view of these findings, even though it was CK7 positive and not 20 positive, we did change the diagnosis, stating that this is a metastatic neuroendocrine carcinoma, most consistent with metastatic Merkel cell carcinoma. The patient is now receiving immunotherapy. A brief overview of pulmonary neuroendocrine neoplasms. The precursor lesions include diffuse idiopathic pulmonary neuroendocrine hyperplasia, or DIPNEC. There is neuroendocrine tumors. The tumorlets are less than 5 millimeter. The neuroendocrine tumors can be classified as typical and atypical. That's typical carcinoid have to be more than 5 millimeter or greater, and less than 2 mitosis per 2 square millimeter. For the practical purposes, on a most currently used microscope, that's about 8 high power field on a 40x lens. Neuroendocrine carcinomas, on the other hand, are higher grade, have more than 10 mitosis per, have to have more than 10 mitosis per 2 square millimeter. In the case of small cell carcinomas, most of them have 60 or more. Large cell neuroendocrine carcinomas have fewer than small cell, but well above 10 per 2 square millimeter. Sorry, this is the improved slide. So typical and atypical carcinoid tumors. Cytologically, we cannot really distinguish between these two unless you see necrosis. The nuclear features are the most important to make the diagnosis. The chromatin pattern, presence or the absence of prominent nucleoli, the regular nuclear membrane, and although occasional random atypical, large atypical cells scattered can be seen, like in any other neuroendocrine tumors, and most cells have run over to spindle-shaped nuclei. Morphologically, we cannot distinguish between lung carcinoid tumors and carcinoid tumors or well-differentiated neuroendocrine tumors from other sites. The growth patterns can be variable, solid, nested, trabecular, and so on. Rosettes can be present, which sometimes can trick people into diagnosing this as an adenocarcinoma, including in large cell neuroendocrine carcinomas. And necrosis by definition only in atypical carcinoids. So let's see an example of a typical carcinoid tumor. This was an aspirate from the lung, and it's very cellular. You can see that a lot of the cells lose their cytoplasm. There's some overlapping, some streaming, and this is important to recognize that even well-differentiated neuroendocrine tumors or carcinoid tumors in the lung when smeared can show this phenomenon, and sometimes, especially in the case of atypical carcinoid, can mimic small cell carcinoma, and therefore the interpretation has to be, we have to be careful. Here is a little less cellular area, the more spindle cell, spindle-shaped nuclei, no mitosis, no necrosis. The Pap smears were very scant. On the right, there's respiratory epithelial cells, and then the nuclei, naked nuclei, the cytoplasm is gone with the speckled chromatin. And here we can see some whirling of these spindle cells. So this typical carcinoid spindle cell phenotype. Here's the resection of this tumor, and it was primarily a nested pattern. Occasional mitotic figures. Again, there's one here, and then after counting multiple fields, it was less than 2 per 2 square millimeter. This is a apoptotic cell. So, and this can be sometimes difficult to distinguish between mitosis and apoptotic bodies. This is another case where this is a subepithelial proliferation. The overlying epithelium shows squamous metaplasia, and the underlying nest have these densely packed oval spindle cells, and with numerous mitotic figures, one here, one here. This is more of an apoptotic cell. So this was a case of atypical carcinoid tumor. And here's the TTF1 staining. About 20%, 30% of atypical carcinoids are positive, 10% of typical carcinoids are positive for TTF1, whereas about half of large cell neuroendocrine carcinomas and 95+% of small cell carcinomas are, at least 90% of small cell carcinomas are TTF positive. In this case, the Ki was elevated, but maybe about 20%, up to 20%, but not 50% or higher. Neuroendocrine markers were also positive. Small cell carcinoma, they have reduced cytoplasm, smudgy chromatin overlapping, nuclear molding, nuclear crowding, coarse granular or smudgy chromatin, a lot of necrosis, rosettes can be seen, and the majority are in current or heavy smokers. Here's an example. The nuclei are larger, the more overlapping, the molding together, and they're more irregular, the chromatin is coarser, there's a lot of apoptotic debris in the background in the smear. And here's the Pap stain where the chromatin is speckled. And then the responding resection, the smudgy chromatin, nuclear overlapping, some smearing, smudging of the chromatin, no nucleoli or very inconspicuous nucleoli. Sometimes the nuclei are big. They say usually it's about 3 times the resting lymphocytes, but they can be big, but the cytoplasm is scant. Ki is very high, and here's the CD56. In this case, interestingly, we also had an area of necrosis where there was fungal colonies, probably mucor, based on the morphology here. And so it was probably a cavitary area in the tumor. Large cell neuroendocrine carcinoma is here, abundant cytoplasm, in contrast to small cell, runt over nuclei, nuclear crowding, nested, slow growth pattern, rosettes, and the majority are again in smokers. The diagnosis on cytology can be difficult because there's a lot of overlap between non-small cell lung cancers, and really the chromatin pattern can be the neuroendocrine pattern of smudgy, coarse chromatin. However, most large cell neuroendocrine carcinomas have prominent nucleoli, which can be on cytology difficult to distinguish from adenocarcinoma or other non-small cell carcinomas. Here, in this case, the cell block, we did not see nucleoli, but there's abundant cytoplasm present, and the Ki was very high in this case, and as was chromogranate. So this was a large cell neuroendocrine carcinoma. We pretty much discussed this in the times of, for the sake of time, I'm not going to go over again. Ki is an important marker. It can be really useful to identify high-grade versus low-grade tumors. We don't have good cutoffs like the GI neuroendocrine tumors have. And generally, it's felt that tumors that have more than 5% Ki, but less than 30%, they're likely to be atypical, and less than 5% favors typical, but there is overlap. We still classify these based on mitotic figures. Okay, moving on very briefly to the last topic. This is a man with a recurrent pleural effusion and no occupational history was available, in a former smoker. This is a pleural effusion, mark atypical cells. They overlap. They have dense cytoplasm, the skirting, prominent nucleoli. They form these balls with these scalloped edges. And here is the cell block. You can see these cell balls, the atypical cells, very quite regular nuclear membrane, prominent nucleoli, and similar appearing cells in the background, some more vacuolated than others. And then like these cells, which are macrophages. So it's a mixture of cells, but some inflammatory, some of these atypical tumor cells. Distinguishing them on a cell block can be difficult on aging section. And here is the corresponding immunostains for carotene, highlighting that most of the tumor cells are in these clusters. As is, EMA is also performed in this case, and EMA is typically expressed in neoplastic mesothelial cells and not in reactive, although 10-15% of reactive mesothelial cells can have EMA expression. BAP1, which is the breast-associated protein 1, is lost here, and the loss is indicative of a malignant mesothelioma. It's seen about 60-70% of pleural epithelial mesothelioma. It's much less common in sarcomatoid. So the diagnosis. Now, definitive cytology criteria is supercellulative and it's very cellular. We get these clusters, dense cytoplasm, berry-like arrangement, and malignant overt features of malignancy are present, like enlarged nuclei, irregular membrane, macronucleoli. Although large nucleoli can be seen in reactive proliferations, binucleation, multinucleation, pleomorphism, atypical mitotic figures. So those are frank evidence of malignancy. Other supportive features are shown here, like pycnotic eosinophilic and orangophilic cells. This can be tricky to people thinking that this is a squamous process. Presence of intercellular spaces, windows, cell arrangements, again, that can also be seen in benign proliferations. Perinuclear lipid vacuoles are another feature. So diagnostic challenges, atypical versus malignant, benign reactive versus malignant. This can be when there's only few cells are seen in single lying in favor of atypical. Papillary configurations can be seen both in mesothelial hyperplasia and mesothelioma. And smooth irregular nuclear membranes favors benign. However, some epithelial mesotheliomas can be very bland. Few examples. This is a case from reactive atypical, showing reactive atypical mesothelial cells from a non-neoplastic, a patient with non-neoplastic disease. And you can see enlarged mesothelial cells with prominent, enlarged nuclei with prominent nucleoli, then cytoplasm, denting the nucleus. But this still is in a patient with no evidence of malignancy. In contrast, this is a case from mesothelioma, like this is tubular papillary structures, then cytoplasm, scalloped edges, some huge vacuole denting the nucleus, but the cytoplasmic borders are these fuzzy versus smooth border in adenocarcinoma. Benign versus malignant mesothelial cells, best marker is BAP1, as it's not known to be positive in benign mesothelium. EMA is less useful. If it's strong diffuse staining is highly suggestive. Does mean we don't use because of the positivity in benign cases, as is GLUT1, IMP3, and P53. These are markers that have been used in the past, but there's a significant overlap between benign proliferations, as is BERI-P4 and MOX31. And the FISH for fluorescent insolubilization for CDKN2A deletion, that's the gene for P16, homozygous deletion is seen in about 75% of epithelial mesotheliomas and none in benign. So that's a very useful method. Here is one. This was a stem prep preparation. 3 atypical cells in the prep, but they show homozygous deletion as a lack of the red signal. Alternatively, you can do immunostain for methylthioadenosine phosphorylase or MTAP, which is right next to the P16 gene. The two are often co-deleted, and this is the normal cytoplasmic expression, and this is in the tumor where it's loss of expression. The immunostain is shown in high power here, is somewhat difficult to perform, and interpretation has to be, internal controls have to work in order to interpret the state. Adenocarcinoma, cell groups, prominent nucleoli, less than cytoplasm, more vacuolation, mucin, and linear nuclear cellular borders are the key features. Here's 2 examples, of mesothelioma and the adenocarcinoma. You can see that the fuzzy irregular border on the outside, the cell ball, where here's the center is more collagenized or matrix filled. Mesothelioma versus carcinoma. The best marker today is Claudin-4, which is an epithelial marker, and which is positive in most epithelial tumors, not just adenocarcinoma. Carotinin is also probably the most specific mesothelial marker, but there's a significant overlap with all these other markers. If some tumors like carcinomas can be positive for specific markers, and they tend to be negative in mesothelioma. A few examples, here's a metastatic lung adenocarcinoma, TTF positive, NAPCA positive, so that's diagnostic. Esophageal carcinomas, gastric carcinomas can be tricky because they often, in pleural fluids, present as single cells that can be difficult to spot on morphologic basis, but is a BERI-P4 and the CDX2 staining confirming the diagnosis. Small cell carcinoma rarely metastasizes the pleural fluid, but it can occur, and it's usually formed with cell balls with the typical, neuroendocrine chromatin pattern, and sometimes have this squamoid appearance. Here's the cell with Ki and CD56. Urothelial carcinoma can also metastasize to the pleural fluid and can have the squamoid, then cytoplasm, sometimes mimicking mesothelial cells, cell arrangements. As here, GATA3 staining and P40 staining is positive in most. However, mesothelial cells, mesotheliomas can also be GATA3 positive in 30–40% of the time. But in this case, carotinin was negative, clinching the diagnosis. They can also be Claudin-4 positive. Any tumor can metastasize. It's an osteosarcoma, patient had a history of osteoblastic osteosarcoma. This is a metastatic rhabdomyosarcoma. It's really looks different from a typical mesothelioma as the rhabdoid appearance, but you have to keep in mind there's a rhabdoid variant of mesothelioma as well. And here's the cell block with the myogenin stain. Thank you. Now we may have a few minutes for questions.
Yeah, thank you so much, Peter. We have quite a few questions. I'm going to let Leslie do that, but I will just say for the group, if you need to go, please go. We are going to let Peter answer a few questions, and we will keep that in the recording. So if you need to go, I know it's late in the day for you, please do. But we will do a couple of questions and put those in the recording, and then we'll stop. Leslie, please go ahead and do the questions.
Yes, thank you so much for that excellent presentation. Let's just go back to the beginning and let's clarify for the nut carcinoma. There was a couple of questions regarding differential morphology and differential diagnosis. For the first case, I believe the question was there any suggestion for nut carcinoma on the morphology? Can we presume nucleolar prominence and less intense blue cytoplasm are soft features? That was the first part. And then consideration of a high-grade neuroendocrine carcinoma in the discussion for that case. Could you comment on that, Dr. Lay?
Yeah, so not carcinoma is, in the initial case I showed that focal squamous differentiation, the squamous eddy was ignored. It was not recognized as such. And that was the clue to that diagnosis. In retrospect, it was there and we could clearly see it. But yes, the difficulty is that most of the time, the not carcinoma can be is mistaken for basaloid squamous cell carcinomas. It's partially because of the morphologic appearance, the focal keratinization, this immunostaining pattern, and the frequency, the common occurrence of HPV-driven basaloid squamous cell carcinomas in the head and neck area that often metastasize to the lung. And so in that setting, I think that's where the differential diagnosis lies. And like not carcinoma, HPV-driven carcinomas can also have a small cell component or can have small cell transformation. So when the morphology appears to be high-grade neuroendocrine or small cell, the features, immunostaining may support that. However, at least in the thoracic cases, the young age of the patient can give away the diagnosis and make the diagnosis, performing the stain. However, I think you need the stain to make a definite diagnosis, unless it's a classic P40 positive with the abrupt keratinization that I showed you. That's highly suggestive of this.
Yes, and so for the other tumor, the SMARC A4 tumors, because of this overlap and the high-grade nature, essentially this would be a diagnosis of exclusion, right? And we would go through all of the more common entities. And then once we are left with all of these other entities excluded, then entertain that diagnosis of SMARC A4, correct? Because I think, clearly immunostains are going to be of limited availability in many scenarios. And so just getting your thoughts about that again.
Yes, so in my experience, when I think of SMARC A4 is a plutidifferentiated neoplasm, but it's keratin positive or negative, and it's usually TTF negative. So we in the lung we do a lot of TTF, and then prominent nucleoli, and that's when it's rhabdoid or hapatoid, it's sort of easier to think about it. But that's when I would order the stain. So I think these plutidifferentiated clinically aggressive tumors that look epithelial, even if they don't stain, and have prominent nucleoli, large nuclei, prominent nucleoli, that's when I think of this entity. And in order to diagnose it, you have to do either mutation studies or immunostains. But that when TTF negative or focal staining, and when you get this weird combination of stains, synapto or glypican, CDX2, but TTF negative, but it doesn't look like any of those tumors that would stain that way. That's when I think of these plutidifferentiated, undifferentiated tumors.
Yes, I think there was another question about the positivity for CDX2, and actually I would wonder why one would obtain a CDX2 in that scenario, but you've mentioned that the CDX2 staining is non-specific, correct?
Yeah, so people, and some of these cases came in consult. CDX2 is used, this presented as a tumor of unknown origin, often in the mediastinum. So then you do your stains, and CDX2 is widely used to intestinal differentiation. However, we have shown, and others have shown, CDX2 can be expressed in lung adenocarcinoma without intestinal features, even some squamous cell carcinomas. In lung adenocarcinoma, 15% of the cases, and in many tumors, thymic tumors, in a lot of different tumors. So I don't rely on CDX2 too much because it doesn't tell me where the origin is. And it tells you, is there an intestinal type differentiation present in the tumor? If I really suspect an intestinal tumor, then I do CK720, and then with the 20 positive, CDX2 positive, that's highly suggestive of a lower GI. But in other scenario, I don't typically use 7 and 20 because it's not helpful at least in the chest.
Understood. And so one last question, and it's going to go towards the morphology. And of course, when we're thinking about targets in the chest, a mediastinal lymph node versus a lung mass, then we are clear on trying to sort out the cells that we have. And you've mentioned several different types of cells in the smear, in your discussions of smears. But one question was if you could repeat the cytologic features of a pneumocyte. So in the pulmonary hamartoma case, which was very fascinating, there was this subpopulation of cells that were picked out, felt to be atypical pneumocytes. So could you please review those features and say that if it got confused with a mediastinal target, can it be confused? Can these cells be confused with mesothelial cells? How do we sort that out? What are some clues?
Yeah, so they can be confused with mesothelial cells, but the features, in my opinion, of pneumocytes in aspirates are they have round oval nuclei, even a distributed chromatin, very regular membrane, the little pleomorphism, low NC ratio, low NC nuclear to cytoplasmic ratio, and forming these sheets. Sometimes you can see inclusions or pseudo-inclusions or bubbles in the nuclei, but you don't see windows, those spaces between the cells. For mesothelial cells, for instance, that's helpful, and the cytoplasm is not that dense. So these are the features of pneumocytes from mesothelial cells. In terms from other like adenocarcinomas, then I refer to it. They are the more regular. They look better differentiated in some sense because there's little pleomorphism, and that's what you can see. If it's an aspirate of a lymph node, mediastinal lymph nodes like station 4 or 7 or something like that, you can occasionally see mesothelial inclusions in those lymph nodes. And although they are typically seen in patients with recurrent hemorrhagic effusions, and outside that, it's extremely rare. Dr. Rosai published a series of 5 cases, I believe, like 30 years ago. And then we've seen like maybe 2 cases in my practice where you could see an otherwise benign, no evidence of mesothelioma or carcinoma in the patient, and then a lymph node with mesothelial cells, typically in the background of pleural effusions.
Understood. Wow, very complicated area, and but we are thankful for your expertise and sharing your knowledge with us. Dr. Miller, is there anything else that you wanted to add before we conclude the session?
No, I don't think so. I think that's really great. We will obviously take this recording and send it to all the participants for them to view at their leisure. And then please look for an announcement for our March conferences. And thank you so much for joining us today.
Thanks again to Dr. Ile and to all of our participants, and we will see you next time. Take care.
Thank you. Bye.
Thank you. Bye.